now I would like to ask Simon to read out the questions.
One other aspect of financialization of healthcare and the unwillingness to train new healthcare professionals is that healthcare workers are poached not only by the private sector, but also by other countries, particularly from the global north, by the global north from the south. What measures can global south countries take to counteract this? And the second thing is, you mentioned the problem of provider-induced demand in social healthcare insurance. We see this in the rise of C-section births, even when they're not needed, as well as oversubscription of medication. How would a revenue finance system, as you described it, address this issue? Can you just elaborate on what you mean by revenue finance system?
Please read out all the questions.
Oh, sorry. You mentioned an increase in food prices. Are these increases a problem of lack of food due to an increase in transportation costs or due to other factors? Both China and Russia have seen bumper harvests in recent years. What role do you see these countries playing for food sovereignty, food security, and improving access to nutritious food? And what, if anything, can be done to hasten that transition? And last, part of controlling one's diet is knowing what food is ingested. Do you see the rise of reliance on delivery services and fewer people having the time or ability to prepare their own food as a potential obstacle for a balanced diet?
Yeah, and we also have some questions written in Chinese. So Tianyu, please read out the questions in Chinese.
教授提到社会保险需要吸纳资金来应对国民医疗的支出，这是因为医疗的成本越来越高。在中国有治胃病的思想，相信在其他地区的传统文化中也有类似的思想。它可以有效地降低我们的医疗支出。我们应该如何将这种思想有效地融入社会医疗保障体系内？还有第二个问题是，中国民众普遍有治胃病的思想，但并不能识别哪些信息是准确的。我们该如何让它在人民中间有效传播，普及民众的医疗知识基础？尤其是我们现在面对着互联网上众多医疗公司的过度宣传这一些事情。谢谢。
Personally, I find it quite difficult in many societies to discourage emigration of healthcare personnel. For example, you now have schools, nursing schools in the United States, in the Philippines, which are dedicated to sending people, you train people to be sent abroad. There are also other places, for example, in Anglophone countries in Africa, such as Zambia and other countries in East Africa, where they are training a lot of nurses and doctors who subsequently emigrate. In a society to discriminate against them in particular, especially when in the case of the Philippines, they have borne the cost of their own training and education with the expectation of earning much more. It's very difficult to refuse to allow people like that to leave. So it's very important to create the conditions for service to basically induce people like that to remain within the country. There are many ways to do so, and I think one should also think of a number of incentives, not just material incentives, but also moral incentives. And this has proved quite successful in many societies. One of the countries with a great number of healthcare personnel is Cuba. Cuba has trained a lot of healthcare personnel, and many of them have served overseas. Now, undoubtedly, we cannot deny that a few have continued to stay overseas, sometimes refusing to go back. But the vast majority goes back to Cuba. So we need to begin to think about the kinds of incentives, because people are not driven by making money alone. And this, I think, is extremely important. The people who are driven by making money, whether they stay within the country or not, do not stay within the country, will have different types of consequences, which are very difficult to anticipate and to make very great generalizations about. The second question, which Simon read out, if I understand it correctly, was about unnecessary procedures. How do we discourage unnecessary procedures in a revenue-based system? Let me. I didn't have time to elaborate, but I think it's very important for us to recognize that once you have a revenue-based system, you can also change the incentives for healthcare. So healthcare providers right now are paid, whether in a market system or in insurance system, they are basically paid and remunerated according to the procedures which are conducted, necessary or unnecessary. And this is a major problem. And correctly, I think we all recognize that. However, you can also change incentives. For example, in a market system in the UK National Health Service. In the National Health Service, you have a so-called capitation system. So all doctors are paid according to the number of people under their care. Okay, the people involved in the NHS, they are paid up. So it is the incentive then is to keep them in good health, keep them, incentivize them to keep the people under their care healthy, so that they do not need to come to seek health. And this involves a great deal of preventive health, and so on. So the incentives are very different when you have remuneration based on the people under your care, you know, and this is so you may have more people under your care in the urban areas where they can come to see you more easily. In rural areas, you may have less people, and all these things need to be adjusted under specific conditions, because it costs money for healthcare providers to go out to the countryside. It also costs money for people to come to seek healthcare. But you basically are changing the incentives. So you're changing the remuneration is linked to people who are in good health rather than people who need curative services. And this, I think, basically is fundamental for the success of preventive health. The third question was on the question of food price increases. Food prices may increase for many, many reasons. Historically, of course, even in non-market-based economies, when you have a poor harvest, or when you are not able, because of drought and so on, you are not able to get enough food produced, and food prices may increase in a market system. We also know that in non-market systems, societies often are organized differently, and sometimes it can be handled equitably, but there's no guarantee. You could also have situations where people who are older, or people who are of different caste, and so on and so forth, are left to be much more exposed to health-threatening conditions. So we cannot assume that just because you do not have a market system operating, that the outcome will necessarily be equitable. But the point really is that the food. Sorry, when it comes to food, what we have in the case of Russia and Ukraine, when the war started in 2022. In fact, both Russia and Ukraine had the highest output as far as wheat was concerned, and so on. So why did food prices go up? Food prices went up because there was a lot of speculation and the speculation was moved by the big speculators, because as you all know right now, incentives are the main speculators are very, very big investment houses. And when you have that kind of a situation, you had the food prices going up, especially during the second quarter of 2022. But when it became clear that there was no real food shortage, prices came down. Okay, so you can have food prices going up because of speculation. You can have food prices going up because of real shortages. You can have food prices going up because of localized shortages. And as we all know, in many situations where it is not really a question of whether you have real shortages, but really the ability of poor people to secure that food, to buy the food, even if it's available on the markets. So you have a situation, for example, during the food crisis of 2008, where you have a situation where there was not where the food was available, but people simply could not afford it because of the contraction, even in some of the rich countries in the West. So I think it is we cannot make generalizations. We have to look at particular situations and what causes prices to go up. The last point, sorry, I think that was those were the three questions, if I understand correctly. But Simon may correct me if I'm wrong. Thank you very much for